Medicine, and I'm also a physician, but I'm a kidney specialist, and I coordinate grand rounds, and I'm actually the chair of the Department of Medicine as well at the Moi University School of Medicine. So today we are really honored to host all of you for a special edition of grand rounds of the School of Medicine at Moi, and this was done really to commemorate the month of May. And in May we celebrate, or we think about GBS, Guillain-Barré Syndrome, and CIDP, which is chronic inflammatory demyelinating polyneuropathy. And at the request of the GBS Foundation Kenya, who are really keen to see GBS and CIDP awareness increase in the country so that more attention is paid to it, we decided to host these grand rounds on a special day, on Monday as opposed to Thursday, also because Prof was only available today. And the main aim today is to disseminate the knowledge about GBS and CIDP to everyone, so that we highlight the plight of some of these patients and highlight also the expertise that is available to us in terms of treatment and care of these patients. So welcome everyone to Grand Rounds, which is an academic activity of the Moi University School of Medicine. And like I have said, today we are really honored to have Professor Eroboghene Ubogu from the Division of Neuromuscular Diseases at the University of Alabama, Birmingham in the United States. Prof, it's really been kind of you to give your time this morning in the US and this afternoon in Kenya to teach us and talk to us about GBS and CIDP. So without wasting much time, Prof, I would like to invite you to give a talk, and then we'll allow for Q&A at the end of your talk. Welcome, Prof.
Thank you, Dr. Koech. It's a great pleasure to be here with you. It's an honor and privilege to share my knowledge. I know we've got a diverse crowd of both clinicians, patients, and patient advocates. So it's going to be a generalized talk in that format. So what are we going to do today? So I'm going to basically define autoimmune polyneuropathies and discuss the major subtypes, which are Guillain-Barré Syndrome, acronym is GBS, chronic inflammatory demyelinating polyradicular neuropathy, acronym CIDP, and vasculitic neuropathy, or VN. So crucially, I would like to share how you can recognize these disorders, then how these disorders are diagnosed, and we'll talk about treatments because treatment is important for optimal outcomes. So what is autoimmune? Autoimmune simply implies that the body is attacking parts of itself as if those parts were an infection or a foreign body or cancer that doesn't belong there. So auto means self, immune is the immune system. And that's the system that exists to help us fight against infections. Polyneuropathies means many nerves of the body have affected, poly meaning many, and neuropathy means nerve diseases. Polyradiculoneuropathy means many nerves and nerve roots of the body are affected, many being poly, radiculo meaning nerve roots, and neuropathy, nerve disease. When we talk about the term acute, it means that from the beginning of symptoms to the maximum severity is less than 4 weeks. When we talk about subacute, it means that the time from the beginning of the symptoms to maximum severity is between 4 and 8 weeks. And when we talk about chronic, it implies that the time from the beginning of symptom onset to the maximum severity is greater than 8 weeks. So autoimmune polyneuropathies, what caused this? We really do not know, but what has been observed or studied over the years is that a combination of genetic and environmental factors make the body think that its own nerves and nerve roots are sick, and as a consequence require a breakdown. These are not very common disorders like I'll talk about, but as I'll also emphasize, the impact can be devastating, not just for the individual affected, but for their families and actually the community and nation as a whole. Common triggers for autoimmune polyneuropathies include infections, many times gastroenteritis or respiratory tract infection. Sometimes patients develop these days to weeks after surgery. A minor injury or significant stress can be a trigger for these. It's important to recognize that these disorders can affect nerves or nerve roots in any part of the body, but most commonly what people experience symptoms in the feet, in the legs, and the hands. There's some conditions that affect multiple parts of the body, so what we call multi-organ disorders, that can also trigger of these autoimmune neuropathies, disorders like diabetes, or where it's more challenging is when the patients don't have any other pre-existing medical conditions and develop these. Unfortunately, these conditions can result in death, chronic pain, and permanent disability if unrecognized and treated, emphasizing the importance of early recognition by patients so they can seek medical attention, and then by medical professionals to identify these disorders and treat them to maximize outcomes. So autoimmune polyneuropathies, there are many, many types and subtypes, but I'm going to talk about the major ones. Guillain-Barré Syndrome, chronic inflammatory demyelinating polyradicular neuropathy, CIDP, and vasculitic neuropathy. Like I alluded to previously, recognition is crucial, not only by patients and healthcare providers, so that patients can seek medical care, so that healthcare providers can make the right diagnosis and start treatments that could prevent chronic pain and disability. It's also important for the community and government stakeholders to be aware of these conditions, because adequate resources are necessary to adequately care for affected patients. And with that care, you can maximize their recovery, which will allow them restore their lives, help them support their families to the best possible way, and then result in self-reliance, which unfortunately can be lost in this group of disorders. Restoration of self-reliance and economic productivity will help the community and the nation as a whole. So what is Guillain-Barré syndrome? Guillain-Barré syndrome is an acute disorder that affects the peripheral nerves and nerve roots. Typically occurs at all age groups and is considered to be the most common cause of sudden muscle paralysis in the world. About 0.5 to 10 cases per 100,000 persons per year occur. Unfortunately, has a 5% death rate. With adequate treatment, about 50 to 75% of people may recover. About 25% are permanently disabled. And those who recover, unfortunately, never recover back to the previous level of functioning. Based on a global estimate of disease index published 7 years ago, 1.2 to 2 per 100,000 persons per year estimated in East Africa in 2019. The most common form of this is a form called acute, meaning maximum severity within 4 weeks. Inflammatory, which means the white blood cells of the body that are part of the immune system are active. Demyelinating, which means that the insulation around nerves and nerve roots are primarily attacked. Polyradicular neuropathy, involving multiple nerves and nerve roots. This is the most common form worldwide. So with an estimated population of Kenya of 59 million, you expect 700 to 1,200 individuals affected every year, with a male to female ratio globally of 1.5 to 1. Although one may argue, oh, these are rare conditions when you think about the burden of other diseases, for example, diabetes or infectious diseases in Africa. One has to recognize that based on 2026 U.S. estimates for Guillain-Barré syndrome alone, the financial cost and economic burden is about $3 billion US, which is 0.35 billion or 350 million in direct medical costs and 2.65 billion in indirect costs due to loss of employment, productivity, as a consequence of disability and failure to return back to previous level of functioning and premature death. Converting this to Kenyan shillings, this is 390 billion estimated in 2026, of which 46 billion is the cost for direct medical care, and 344 billion indirect costs due to lost productivity and premature death. This equates to 325 to 560 million Kenyan shillings per patient affected. This is just a picture showing here with the black arrow the Kenyan estimate of Guillain-Barré Syndrome in this worldwide map. And you can see in general in East Africa, we're talking about 1 to 2 cases per 100,000 per year. And that's based on what is estimated. What is CIDP, or chronic inflammatory demyelinating polyradicular neuropathy? Many times this is not recognized because it's a chronic disorder, slowly progressive, that may evolve over several months, sometimes even years. However, it's recognized to be a very common cause of neurological disability worldwide, accounting for up to 14% of patients who are disabled with peripheral nervous system disorders. In terms of new cases, 0.5 to 5 cases per 100,000 persons per year worldwide. So currently, there are about 5 to 10 persons per 100,000 living with CIDP worldwide. So with the Kenyan population estimated at 59 million, newly affected patients about 300 to 3,000 every year. A number of individuals living with the condition, 3,000, 6,000 in the population, with a male to female ratio of 1.5 to 4 to 1. In terms of economic burden from CIDP based on US estimates, just for medical treatment alone, we're talking about $150,000, which equates to 20 million Kenyan shillings. And this excludes the loss of funding or support from individuals who are unfortunately afflicted with CIDP in terms of their productivity and not being able to return to the workforce, or from the families having to support them and not being at their best productivity economically. And the loss of productivity is estimated to be 6 to 8 times the direct healthcare costs. So for using US estimates, the direct annual cost of healthcare, not to include the loss of productivity, in Kenya should be about 60 to 120 billion Kenyan shillings. Vasculitic neuropathy is a condition that tends to occur in inflammatory diseases that affect the blood vessels in several organs of the body. It's estimated about 60 to 150 million per million persons develop this per year, with 30 to 50% of individuals who have these conditions, the vasculitic diseases, developing a polyneuropathy, which equates to 18 to 75 per million. There are patients who only develop disease in the peripheral nerves, which is called the isolated or non-systemic vasculitic neuropathy. It's hard to come with more precise estimates of patients with these conditions worldwide, probably because they are under-recognized. But with a population of 59 million estimated in Kenya, there are probably 1,100 to 4,500 patients dealing with these group of inflammatory conditions in the peripheral nerves. In terms of sex ratio, it may slightly affect more men than women, but it also depends on what the underlying cause is of the condition. Vasculitic neuropathy is a major cause of chronic neuropathic pain and disability, with estimated $52,000 per patient per year in the United States in direct healthcare costs, which excludes the loss of productivity due to chronic neurological illness. With that being said, the estimated cost in Kenya will probably be of the order of 7.7 to 31.5 billion Kenyan shillings, recognizing that although this is a rare condition, the economic cost and financial burdens are quite significant. So why is it important to recognize these conditions? Like I mentioned previously, recognition is important not just by the patients, but by healthcare providers so that the diagnosis can be made and treatment started as quickly as possible to improve outcomes. So with Guillain-Barré, the clue is a sudden and rapidly progressive loss of muscle strength or change in sensation. Many times patients may complain of tingling sensations, they may complain of feeling numb, and symptoms typically start in the toes and the feet and move up the body quickly. In some cases, the symptoms start in the arms and shoulders and work their way down quickly. And quickly, we're talking about days, rather than months, where symptoms worsen and move to other parts of the body. The muscles of the face, throat, and chest can be affected by Guillain-Barré syndrome, which causes difficulty speaking, difficulty chewing, difficulty swallowing, and difficulty breathing. In some patients, the heart, the gastrointestinal system, the bowels, and the bladder can be affected. And patients may complain of symptoms such as feeling faint or lightheaded, may have uncontrolled or irregular bowel movements with diarrhea and constipation, or frequent urination or inability to urinate. As alluded to earlier, these symptoms can evolve very quickly over several days to less than 4 weeks, and that's why we call it acute. And most scarily can cause paralysis, where individuals affected are unable to move, and this is considered a neurological emergency due to the risk of causing problems with breathing, swallowing, and heart function that can result in death. This picture kind of depicts with the black arrow the most common form you see in Guillain-Barré syndrome, where the entire body is affected and both the muscles, the motor system, and the sensory system, the perception of touch and feeling are affected. There are several different subtypes. I wouldn't go into those, but what is important to recognize is that the entire body can be affected by Guillain-Barré, and it's a neurological emergency. In the less common forms, it's important for healthcare providers to consider Guillain-Barré, even though it doesn't fit the classic form, especially if the history suggests very rapid progression over days. With CIDP, like I said, sometimes this is not recognized because it's a gradual and, in many cases, slowly progressive loss of muscle strength or change in sensation. Typically affects the toes and the feet first, then gradually moves up the body to the legs, then moves to the fingers and the hands over months to years. One side may be affected more than the other. Doesn't commonly affect speaking, chewing, swallowing, or breathing. Doesn't commonly affect the heart, the bowels, or the bladder. In patients, they may have a form where they get worse, then they get better, which we call relapsing remitting, or they gradually keep getting worse without any improvement, which we call progressive. In older people, many times it's not recognized as a neurological condition because people say, oh, you're just getting old, that's why you're not walking properly, or you just have arthritis, that's why your muscles don't move, that's why your joints ache. So it's important to consider this and not overlook it because treatments can change outcomes. CIDP is a common cause of chronic pain and disability if unrecognized and untreated. And the picture here kind of depicts the forms of CIDP. The typical form is where the motor, the muscles, and the sensory nerves are affected and affects like I described, the feet, the legs, the hands, and the arms. There are other variants of presentation that may occur, and it's important for healthcare providers to recognize these, especially in patients who gradually develop these symptoms for which there's no apparent cause, such as diabetes. With vasculitic neuropathy, it's more challenging to recognize because there's a variable loss of muscle strength or change in sensation. It may start in one limb, the hand or the foot, with sudden pain, followed by loss of sensation and weakness, which acute being, over days, less than 4 weeks, or may occur less rapidly with one or several limbs affected, 4 to 8 weeks being subacute, or over several months to years or chronic, with differences in severity between the sides. It could affect speaking, chewing, swallowing, and breathing, the heart, the bowels, and the bladder, but typically not as severe as one will see with Guillain-Barré Syndrome. Similarly to CIDP, patients may worsen and get better, which we call relapsing remitting, or keep worsening without any improvement, which may be what we call stepwise, where a patient declines very quickly, stays at that level for a long time, then declines again quickly, or a gradual progressive loss of function. Many times it happens in patients who have multiple organ blood vessel inflammation, and it's important for clinicians to recognize when this happens, even though they may be focused on other systems of the body. Recognize this is important because unrecognized and untreated, vasculitic neuropathy can cause chronic pain and disability, which can have devastating effects not only for the individual, but for their family and as the nation as a whole. So this picture here depicts what typically a vasculitic neuropathy patient may look like. The arrow points to what's most commonly the case, where there is one arm or one leg, one hand, one foot may be affected more so than the other. So what usually distinguishes this from CIDP is the fact that you have the asymmetry with one side more affected than others, more so where CIDP tends to have sides more similarly affected. So how do we diagnose these? Patient recognition is important because if the patient does not seek medical attention, medical providers will not be able to evaluate the patient. But for the clinicians, it's important to recognize that a careful and comprehensive clinical history and physical examination is required. Polyneuropathies can come from many, many conditions, the most common one being diabetes, but also vitamin deficiencies, chronic alcohol use, infections such as HIV and syphilis, cancer and cancer-treating drugs, toxins and chemicals can cause polyneuropathy. So when you're thinking about an autoimmune neuropathy, the history is important because one has to be able to differentiate that from other causes so you can direct patients to the right treatments. Laboratory investigations typically in a resource-rich environment will include cerebrospinal fluid analysis and muscle and nerve biopsies, as well as electrodiagnostic testing. And I'm going to talk about these individually. So when taking the clinical history as a clinician, one has to ask the question, what are the symptoms? Are you having weakness in one limb, weakness in both limbs, upper, lower? Is it sudden? Is it gradual? What part of the body was affected first? Have symptoms evolved? And are there any ongoing illnesses or infectious exposure or any surgery or stress or anything that could have happened preceding the onset of symptoms? For the clinicians examining the patients, you want to check for change in muscle tone and muscle bulk, perform an examination of the cranial nerves, and strength testing on confrontation, which we classify using the MRC Council scale to document weakness, recognizing that weakness can be in one limb or could be in all four limbs as in Guillain-Barré, or in single limb as we find with vasculitic neuropathy. Checking the sensation, a loss or increase in sensory perception in a length-dependent pattern, or in a radicular pattern, or what we call dermatomal, or in a single peripheral nerve distribution could help the clinician figure out what the underlying cause is. Reflex testing, reduced or absent tendon reflexes are expected with this group of conditions, And with the walking, one may find that the patient has problems with their balance or is walking with what we call a high steppage gait, where they're lifting their feet really high up in order to walk because of weakness in the foot. Laboratory testing, one would like to be able to exclude other potential causes that may have different treatments. But one may recognize that this could be challenging in a resource limited environment. I've listed common tests that are done to evaluate patients who present with signs of a polyneuropathy or polyradiculopathy. In the diagnosis of CIDP and Guillain-Barré, cerebrospinal fluid analysis really makes a difference. In the diagnosis of vasculitic neuropathy, nerve or muscle biopsy really makes a difference. These are not necessary to diagnose Guillain-Barré and CIDP. So having access to cerebrospinal fluid analysis could be really important because, and I'll show you in a second, it can differentiate between Guillain-Barré or CIDP from other forms of polyradicular neuropathies. So cerebrospinal fluid analysis requires something called a lumbar puncture or spinal tap, where a spinal needle is usually introduced typically in the low back, the lumbar spine, into the spinal space, and fluid is extracted from the spinal fluid for analysis. In Guillain-Barré and CIDP, an increase in the spinal fluid protein with normal white cell counts, which is known in medical terms as albuminocytology dissociation, helps make the diagnosis. In patients who have an increase in spinal fluid protein and a high white cell count, then there's infections, other inflammatory conditions, cancer like
Is it only me or?
No, I think we lost Doc. I can see everything, but I'm not hearing any sound.
Prof, it seems like your audio and your connectivity.
Doc, maybe someone should reach out to him because he's continuing with several slides now.
back a few. I'm not sure where I froze out, but let me go to diagnosis. Okay, so the diagnosis of these conditions requires careful and comprehensive clinical history and physical examination. It's important to recognize that polyneuropathies are more commonly caused by other conditions, with diabetes mellitus being the most common cause worldwide, but also vitamin deficiencies like vitamin B1 or B12, B6, alcohol use, infections such as HIV, syphilis, cancer and cancer-treating medications, toxins or chemicals. Typically, the laboratory investigations important to make a diagnosis include cerebrospinal fluid analysis and a nerve and muscle biopsy. Then electrodiagnostic testing is important to help not only make a diagnosis, but to characterize this group of conditions. So from the clinical perspective, for the clinicians, what are the symptoms? When did they start? What parts of the body were affected? How quickly have things evolved? And were there any ongoing illnesses or any preceding illnesses that happened before the onset of symptoms? When performing a clinical examination, it's crucial to look for a change of muscle tone and muscle bulk, perform a cranial nerve examination, and confrontational motor strength testing using the MRC Medical Research Council scale. With sensory examination, one is looking for a loss or increase in sensory perception to light touch or pinprick in a length-dependent or radicular, which we call dermatomal, or single peripheral nerve distribution, because this can distinguish between these conditions and points to one or the other. Reflexes are typically lost or reduced with these conditions. And gait, patients may have imbalance, which we call it ataxic gait, or high steppage gait, where they're walking, lifting their feet very high off the floor to prevent them from tripping due to weakness in the foot. In a resource-limited environment, it may be hard to perform comprehensive laboratory testing because the resources are not there. But what I've listed are common tests that are done to evaluate patients with this group of conditions, with the aim to exclude other causes of polyneuropathies. Cerebrospinal fluid is required for the confirmatory diagnosis of Guillain-Barré and CIDP, while a muscle or nerve biopsy is required for the confirmatory diagnosis of a vasculitic neuropathy, but not necessary for Guillain-Barré or CIDP. CSF, cerebrospinal fluid analysis, involves performing what's called a lumbar puncture, also known as a spinal tap, where a spinal needle is placed typically in the low back, in the lumbar spine territory, and fluid is extracted from the spinal space and analyzed. With Guillain-Barré and CIDP, there's typically an increase in the protein levels with a normal white cell count, which in medical terms we call the albuminocytologic dissociation, and this is what is expected for Guillain-Barré and CIDP. Where there's an increase in CSF protein, an increase in the white cell count, this could be due to infections, other causes of inflammation, or cancer like leukemia or lymphoma. So this is why it's important for the cerebrospinal fluid analysis. When it comes to making a diagnosis of vasculitic neuropathy, one would like to be able to perform a nerve or muscle biopsy with the white arrows showing the inflammation in the tissue, and the nerve biopsy and muscle biopsy that help confirm the diagnosis. And this is important because many times you're giving patients very potent medications for long periods of time. And when that is going to be the case, one has to be sure of the diagnosis because some of these medications, in fact, many of them can have side effects. Electrodiagnostic testing encompasses two parts: nerve conduction studies, where we evaluate the size and speed of the electrical impulses from individual motor and sensory nerves, and needle electromyography, where we evaluate the integrity of the electrical signals coming from individual muscles. Combining these tests, we're able to determine the pattern, severity, chronicity of peripheral nervous system disorders, and can localize where the problem is coming from, which is important in making a diagnosis of an autoimmune polyneuropathy. And as a consequence, one can distinguish between the different subtypes using this technology, recognizing that these may not be readily available in many countries around the world, apart from specialist medical centers or centers of specialist neurological expertise. With Guillain-Barré syndrome, the electrodiagnostic testing shows demyelination, which is slowing that occurs as a consequence of injury to the myelin or the nerve root of the nerve sheath, or axonal loss, or both, involving motor and sensory nerves. With the needle exam, needle electromyography, we see acute changes in the innervation pattern in the weak muscles, and we see involvement of multiple nerves and nerve roots. Typically with Guillain-Barré, like I showed in the picture earlier, you get similar involvement on both sides of the body. With CIDP, what typically happens is you get demyelination or axon loss or both, involving motor and sensory nerves, chronic changes on the needle electromyography in clinically weak muscles. You also have involvement of multiple nerves and nerve roots, and similar involvement on both sides of the body. With vasculitic neuropathy, typically what you'll see is axon loss pattern in motor and sensory nerves, which could be acute, subacute, or chronic in the innervation in clinically affected muscles, and you tend to have multiple nerves affected. It's common that one side of the body may be affected worse than the other, especially early on in the disease onset. Many times, diagnostic study is important to help determine which muscle or nerve should be biopsied to confirm the diagnosis. Of the treatments available, for the last 45 years or so, it has been shown that Guillain-Barré syndrome responds to intravenous immunoglobulins and plasma exchange. The access to these can be a challenge, especially in resource-limited environments. However, these are crucial to prevent patients from progressing to the point of death, and in many times stop progression in symptoms that can result in recovery and prevention of disability and chronic pain. With CIDP, there are more options. Typically, immunoglobulins, which can be given through the veins, intravenous or subcutaneous in the skin. Oral immunosuppressant medications such as azathioprine, mycophenolate mofetil, methotrexate, and cyclosporine are options for patients. With vasculitic neuropathy, corticosteroids like prednisone, prednisolone, oral immunosuppressant medications. In patients who don't respond, intravenous cyclophosphamide. And if the patient has a systemic inflammatory disorder involving the blood vessels, you want to treat that condition as well. In addition to the treatments available, it's really important that patients get the right kind of supportive care. This is important to prevent or treat complications of chronic immobilization, to treat acute and chronic pain, and to start rehabilitation as soon as possible to hopefully improve outcomes. Early diagnosis is important because if one presents with these symptoms, and for example, it's not recognized that they've got diabetes and they're given steroids, steroids can make diabetes worse, can make the patient worse. If a patient presents with symptoms of Guillain-Barré syndrome and they're treated with steroids, steroids do not work with Guillain-Barré syndrome, can actually make patients worse. So, in addition, patients who do not receive the right diagnosis of CIDP, for example, can develop irreversible weakness and loss of sensation, that will cause disability, while if recognized early, corticosteroids given early can treat CIDP effectively. So ultimately, early recognition is important because early recognition results in early treatment. Early treatment results in the best chance for recovery and restoration of function. And in that way, you prevent disability and
Recording in progress.
And an inability to swallow and breathe, which can result in death. Public awareness is crucial because one has to recognize these disorders as a patient or patient's family members and seek prompt medical attention and care. Healthcare provider awareness is important to appropriately diagnose and treat these disorders to maximize patient outcomes. Government policymaker and community awareness is essential to ensure adequate access to treatments and the resources required to support patients and their families and their caregivers, especially in resource-limited settings. So once again, I would like to thank Collins Kiplangat and the GBS Foundation Kenya for the kind invitation, and to Moore University School of Medicine for this invitation to talk to you, and to all those who are able to join us this evening in Kenya for your time and your attention. And I'm open to questions at this point in time. Thank you.
Thank you very much, Prof. We really appreciate. I know you're a busy person. You have many responsibilities, and we were not able to get a hold of you on our Thursday grand rounds, but we hope one of these days you'll also get time to give up grand rounds. This was also a grand rounds, but I mean our regular Thursday grand rounds for the School of Medicine. When you have time, I know Thursdays you're busy at the lab at your neurology lab and your neuroscience lab. So, like you said, I think this was done in commemoration of the GBS Awareness Month, which is the month of May, both for GBS and CIDP.
Hello, everyone. My name is Collins Kiplangat from Kericho, and I was diagnosed with GBS back in 2018, I think. First and foremost, I would like to say thank you for Professor Ubogu to agreeing to give this lecture, and I would also like to say thank you for Dr. Mathew Koech and the entire team that bit about my GBS story, but we don't have time. And most of the time when we tell our GBS stories, it becomes a story of resilience, but there are also losses. About a year before I got sick, there was one Edu who fell ill with GBS, but unfortunately we lost him because it took the doctors quite some time to figure out what was wrong with him. So I know this lecture was specifically for medics. Please remember what you've learned today, and I'm pretty sure at some point down the line it would save lives. Thank you. That.
Thank you, Professor. Thank you, Dr. Koech, for a great lecture. And thank you so much, Dr. Koech, for coming in on behalf of GBS Foundation to help us create awareness. It has been a great took your media podcasts and just gave it to GBS survivors to share their story and to bring more awareness in this country, because this is what we need. I was diagnosed with GBS in 2022 July, And whatever Professor is saying as early signs, I experienced all of it. And just looking at the situation in Kenya right now, and the reason why we had to come online and look for more GBS patients to form this foundation is to bring awareness. And today it's a great honor that we are bringing this awareness to the doctors, to the medics in this country, because that is where the big problem is happening. It took me like 4 days for the hospital to diagnose my case. And I thank God I was in city and I was in one of good facility, but still 4 days, which was a bit late. By the time they came to recognize that it's GBS, I was fully paralyzed. So I want to say, GBS, it's not often as it's being, it's not often as it's being said. And the truth is GBS is very expensive, and that's why many patients remain to be disabled for lack of treatment, because it's remain to be disabled for lack of treatment because it's very expensive. It's not covered with our association, so they still remain on the wheelchair. And this is really affecting because majority happens to be young people. So with Dr. Koech bringing the University of Moi on board for medics, it's a very encouraging moment just to know that the world and Kenya at large is coming to know more about GBS, and a life shall be saved through this. Thank you so much. Thank you, Dr. Koech.
Thank you, Violet. Kipkeme, you want?
30 seconds. I'll just GBS team for coming out and agreeing to share their stories. I think that's very encouraging. That's very powerful of them. And also allowed you, Dr. Koech, for allowing us use your platform and your podcast to create awareness about GBS. I think going forward, probably as we commemorate this year's GBS awareness and the campaigns that we've done in 2026, maybe to the GBS Foundation team, we can plan for a better and a bigger kind of campaign in 2027 so that we reach even more people and involve more healthcare facilities as we champion for the inclusion of GBS into the our patient care in Kenya and many others. And even the research that have been shared by Prof. I think looking at the numbers from my interaction with the people that have been affected, I think the numbers are much higher, especially in Kenya. So I think the medics and the institutions that are in charge and even the universities need to look really critically into this matter so that we have accurate numbers, accurate diagnosis in time, and also treatment that is in time and affordable. Thank you.
It seems like there are some questions.
Yeah.
If I can go through those.
Yeah. Neurologists here at Moi University to also make a comment. But maybe, Prof, you can answer questions in the meantime. Jamil, get ready.
One is from Dr. Jamil Said. He says there's no access to nerve or muscle biopsy in Kenya, and he's been exploring the potential use of nerve ultrasound in the diagnostic evaluation of non-systemic vasculitic neuropathy, complementary to the clinical phenotype, especially those patients who have negative anti-neutrophil cytoplasmic antibodies. So what are my thoughts about this? I'll say that with well-trained hands, the ultrasound is an important adjunct. The advantage you have with vasculitic neuropathy is that especially if you have a patient with the pattern what's called the mononeuropathy multiplex, where individual nerves, multiple of them are affected, ultrasound can help you determine where you have areas of swelling, which can equate to evidence of inflammation. So I think it's reasonable. The crucial thing is to be able to get the right training and expertise and the experience so that one can distinguish that from other causes of compressive neuropathies, for example, carpal tunnel or ulnar neuropathy at the elbow, or common perineal neuropathy at the knee, at the fibular head. Another comment about the time it takes for irreversible damage to occur with CIDP. It's hard to say because there's a lot of variability in CIDP severity. I'll say that the key thing that results in irreversible damage, the two factors: one, time. So the longer you have CIDP that's untreated, the more likely you are to develop irreversible damage, and the degree of axonal loss. The axon is the part of the nerve or the nerve roots that transmit electrical impulses, what we call the cable of the nerve. And if you have early or widespread involvement of that, that doesn't recover. While the myelin sheath, the insulation around the nerve and the nerve roots, has a higher chance of recovery when treatment, usually in the order of weeks. So the thing is, early recognition results in treatment that prevents disability. But I have to admit, even in patients who are well treated, because these are chronic disorders that we don't have a full handle on, patients can still progress to disability over many years. But the important thing with CIDP is you have to make the right diagnosis and start treatments and do all the right things, not just the medications, but the physical therapy and all the other factors, all other recommendations. Then you can hopefully slow down progression. In terms of the financial burden, I use the U.S. estimates, of course, but I think it's important for healthcare economists in Kenya and in other countries to look and see the burden. I think many times the focus also is on how much does it cost us to treat the patient in the hospital? What burden is that on the healthcare system? However, many times the stakeholders don't look at the cost of loss of employment, the cost of loss of productivity, the family burdens, and how that impacts the economic well-being of the nation as a whole. So you may say it's a rare disease, but if a rare disease costs that much for an individual, not just healthcare costs, but also loss of income, then it tells you that there's a major problem and it's definitely worth investing to treat the patients so they can be productive for the sake of themselves and their families.
Thank you, Prof.
Thank you, Prof.
Jamil, you want to say something? Jamil is a local expert here, sees a lot of GBS and other variants locally. Jamil, maybe you can put perspective for Prof. Prof, have you been to Kenya?
No, I haven't been to Kenya.
You'll be here soon.
Okay, yeah. My pleasure.
Yeah, looking forward to hosting you. Thanks, Prof, for that excellent overview and sharing the insights on the role of ultrasound, especially in this part of the world where we don't have access to biopsy. So I don't think any part of Eastern and Central Africa can reliably do nerve biopsies and muscle biopsies. And I suspect the entire continent does not have the capacity for muscle biopsy, the entire African continent, but I'll have to counter check on that. So that's why we are exploring, other complementary testing that we can offer for these patients. And I'm also happy to announce we just started the Kenya Neuroimmunology registry recently. We're planning to collect data both retrospectively and prospectively for both disimmune neuropathies as well as central nervous system autoimmune neurological conditions, because we're seeing a very huge burden of these conditions, especially in this part of the country. Around agrarian communities. So I don't know if there's an environmental or a genetic overplay that is driving this, because we don't see the same pattern in other parts of the country. And as GBS Foundation mentioned, the government does not have neurology as a department at the Ministry of Health. So it makes advocacy extremely difficult. We're currently lumped under mental health. And in all the 20 mental health priority conditions, none of them is neurological. And that's why we have to fall under rare disorders. And maybe this is something GBS Foundation can take up, follow Prof's advice, do an economic surveillance, cost, impact, and then submit that document to the Ministry of Health. And that could be the initial steps towards setting up a neurology department. And it would make it even easy for us to access some of these treatments through the social health insurance cover, because that's been a major challenge. We currently have a patient with CIDP at the hospital here, might require IVIG monthly, and the costs are phenomenal. She's refractory to steroids. So yeah, those are the challenges we are facing here. Sharing your perspectives, Prof.
My pleasure. I think the key thing is not just the autoimmune, but for example, diabetes many times causes polyneuropathies that can result in disability. So if we're trying to get awareness and resources to neurological disorders, I think it's important that as neurologists, you also advocate for other things outside. For example, stroke, is probably a significant burden. You talk about polyneuropathies from diabetes, so other conditions, degenerative spine disease. So I think when you highlight those things that many times are unrecognized in the community, then it's quite clear the burden of neurological is significant. Although we spent our time talking about autoimmune, which is, has a significant financial cost, the other disorders affect quality of life, result in significant burden on families and communities. And when the numbers are put together, you'll find significant compromise to the economic well-being of the nation as a whole that have been unrecognized. So I think it would be good to collaborate and work together, look at your local environment costs, and then awareness is important, because you may have people suffering with these conditions who don't even know what's going on. Where people are using different different hypotheses. Is this witchcraft? Is this age?
Thanks for the insights, Prof. Thanks really. I don't know how much time you still have, Prof, or I don't know whether there are more questions. Do you need to go?
I'm free today. Today's a public holiday in the United States.
Oh, okay.
So I've got plenty of time. You guys said 2 hours.
Mm-hmm.
So I'm free for more discussion. I'm available, no problems.
Okay, more questions? Any more questions from the audience?
Let me ask from the GBS Foundation Survivors Group, a case of where a patient has been asked to use the steroids instead of hemoglobin, IVG. What do you say about it? Because number one, the fear from the group is the steroids has larger side effect to the patient more than having the two treatment, the plasma and the IVG. I don't know how you can respond to that.
Well, I'll say even in resource-rich environments like the United States, the first-line treatment is corticosteroids because it's cheapest. So probably a day of, let's say a month of prednisone will cost $3. A month of IVIG may cost $20,000. So you can imagine, depending on where you're getting the IVIG, whether you're getting a home infusion, whether it's what brand, and of course in the United States we have multiple pharmaceutical companies making IVIG. So so from let's say $10,000, and depending on anything from $5,000 to $10,000, a month compared to $30 a month. So in general, what tends to happen is in our environment, if you do not respond to corticosteroids, or you have adverse effects or side effects from corticosteroids, then the insurance companies are more likely to accept the IVIG. If and on a yearly basis, we have the use of IVIG or subcutaneous IG. So that's where the challenge is. So I think the key point is, if you were to ask me, steroids or nothing, you definitely want to get steroids with CIDP because it can make a difference. The side effects, of course, high blood pressure, diabetes, weight gain, those are things that can be controlled with good medical care. So I'll simply say, if you have access to steroids, it's a good starting point for CIDP. IVIG, many times people don't think it has side effects, but it can. Some patients develop blood clots with IVIG. Some people develop bad headaches, with IVIG. So it's not a benign drug. If it's well made and it's purified properly, and of course the risk of infections and things of that nature are negligible. But ultimately, with CIDP, access to something is better than access to nothing. And when you're in a resource-limited environment, the challenge could be that the IVIG may be, the limited resources of IVIG may be saved for the GBS patients because you don't have anything else. Plasma exchange, even in a resource-rich environment, is limited to specialist centers that have the expertise and the machines to perform plasma exchange. So even in the United States, you don't get plasma exchange everywhere. The drug of choice for Guillain-Barré is IVIG because IVIG is it's purchased from the pharmaceutical company, is more widespread, and it's used for other conditions as well. So I'll simply say with CIDP, if you have access to steroids, it's better to have that than have nothing at all.
Thank you, Prof. So it happens in is very, very expensive because we import it. And therefore plasmapheresis or plasma exchange becomes a bit cheaper for us. I think it comes to about, what, maybe $3,000 to do plasma exchange as compared to $10,000 plus or minus for IVIG. So it's really a big issue here, but those are just some of the differences between the two settings.
I think if you had plasma exchange widely available in Kenya, so patients don't have to travel long distances to go to specialist centers, then it's not a problem because ultimately your economic situation is different. In an environment where a patient, let's imagine there are only 2 centers in Kenya that can perform plasma exchange, and you have a ward that can take 10 people, and you have 100 people coming in from all over the country to get the treatment, then that's where it becomes a challenge because you've got limited facilities to accommodate for all the patients that are affected. So the ideal situation would be to have access to plasma exchange in several centers around the country so that when patients are afflicted with Guillain-Barré, then they can go to those centers and get treatment very quickly.
Yeah.
Thanks, Prof. Now, the other question that I have is slightly outside what you discussed, but I think it overlaps. The polyneuropathies. So we had diagnostic challenges here, but currently there's a lab that we're partnering with through an external commercial reference lab that sends it to South Africa, and we're able to do the neuronal assays. It's still in the validation phase currently, but over the next 1 or 2 months, they'll be able to offer it as a standard testing platform. And I've seen a few cases, that present in a manner phenotypically.
Probably about 5% of those cases may have a polyneuropathy. So having access to the diagnostic testing, and I'll ask when I'm done about access to cerebrospinal fluid analysis. But having the laboratory test is important because ultimately you may have patients with typical CIDP, very severe cases, who don't respond to those or have a delayed response. So I think the key point is if you're able to get the diagnostic testing, the antibody testing cheap and quick, that it's worth doing it in all your patients who you suspect have atypical findings of CIDP. If it's an expensive test, or results take a prolonged period of time, then the approach will be to treat with your standard treatments for CIDP first. Patients do not respond, then you consider those patients who do not respond as potential having a nodopathy or paranodopathy, and then send up the testing. So they're not very common, I will tell you that. If one looks at a large cohort of patients who were labeled with CIDP, you're probably talking about less than 5% have these. So they're not very common. Test costs. For me, the investment, of course, would be on getting rapid access to cerebrospinal fluid analysis. So my question is, how easy is it or difficult to get to do a lumbar puncture and get CSF data in at Moy?
So it's pretty easy, especially for the basics. So very easy to do a lumbar puncture, and we can very quickly get biochemistry. And of course, the other infectious workup pretty easily, including TB GeneXpert. It's a high TB endemic area here. But cell count and cytology is a bit of a challenge. So we don't have immediate cytospin capacity. So cell preservation is not good. So our cytology results are highly unreliable. Cell counts as well, also highly unreliable. However, the workaround that we do currently is the person who's collecting the CSF sample has to walk to the lab and request physically within 30 minutes to get a cell count result. And when that happens, we know that this is a reliable cell count. However, unfortunately, in our setting, we don't have any facility that is able to give you an automated cell count within the required standard time point. So most of the cell counts that we get indicating 0 usually down much later, so probably sometimes even a day later. So they're highly unreliable, not unless we take the initiative and the extra steps to physically chase it and make sure you get a result within the first 30 minutes or 60 minutes at the
Well, it may be something that one could advocate for, having the resources to perform the automated cell counts. Those machines, and I don't think they're that expensive. But of course, it's the preservation of the specimen. Even in our environment, when we do lumbar punctures, we can have the specimen sitting around. We usually have someone take it over to the laboratory. So that may be something to look at. See what the cost is to do automated, cell counts for cerebrospinal fluid analysis, especially in the larger hospitals, where it could make a difference in the diagnosis. Because of course, if you have no cells in the spinal fluid and you have high protein, then you're thinking about Guillain-Barré CIDP. If you have a lot of cells, you may be thinking about something else. The treatments could be quite different. So, of course, the last thing you want to miss is a patient who has leukemia or lymphoma involving the nerve roots and peripheral nerves, because that can be devastating for the patients. But so I think that may be something worth discussing with the hospital administration to see what the investment can be to get automated cell counts in at least in the facilities that have that see a lot of the patients with these group of disorders. And it could also help with meningitis as well. If one wants to sell the point, when you're evaluating patients for meningitis, then having a good cell count can help you make that diagnosis.
Yes, definitely. Yeah. Thanks. So one of our commercial labs here is considering setting up an automated cell count machine in their branch lab here in Eldoret. I don't know how long that's going to take. They promise to have it done in the next couple of weeks to months. So hopefully that would be something. Yeah, and while we are waiting for that, of course, as you mentioned, the plan is to lobby with the hospital to procure one. And hopefully in the future, we'll be able to get one.
But I saw Barnabas Keegan from Pediatric Neurology here. Barnabas, any comment from your side? What's your experience with pediatrics, AIDP or GBS, CIDP in our setting?
Yeah, thank you, Dr. Mathew. Are you able?
Yes.
Yes. So I think a lot has really been said and discussed, and thank you, Prof, for sharing. For children, I mean, it's really just like we said, sends very fast and just calls out for the awareness, as has really been mentioned, and the suspicion that, and I think it tends to be picked more in pediatrics because I guess a lot of things happen. In fact, most of the neurological conditions we see, we are glad that people think about GBS first before we consider other differentials like transverse myelitis and as such. So just being really on the lookout. The only challenge, of course, is that with children, there are many other things that if it occurs in the context of other illnesses that are likely to make a child maybe flaccid or a bit hypotonic, which could result from so many other causes, that could mask. But yeah, we're glad that at least when that kind of deficit, asymmetry, you have this symmetrical ascending paralysis, that really tends to, clinicians seem to be aware of likely possibility. And I think we are glad on that front. Of course, the IVIG issue, from my own experience, SHA has really helped. Even some of the patients that sometimes we see outside the hospital, and MTRH has really been supportive. Whenever it's stocked, it sorts out most of our patients. I've had about 2 or so patients with CIDP. There's one girl who improved. Unfortunately, really again, the delay in diagnosis. That was somebody who had a lot of, symptoms for close to about 5-6 years from onset of symptoms by the time we were seeing them. After a few monthly IVIGs, we got quite some improvement. But like Prof had mentioned, when you've had a lot of delay in physiotherapy, occupational therapy, then again, you may not regain those functions fully. So Dr. Mathew, that's our experience, and it's been a great talk. Thank you.
Yeah, obviously the other advantage is the doses of IVIG are way, way smaller, and therefore the cost becomes significantly cheaper compared to adults.
Oh yes, for sure. Yeah, you're right.
Yeah. Thank you.
I think also with pediatrics, what happens is a child who suddenly stops moving or starts acting differently, the parents or caregivers realize something is wrong. So they're more likely to act on it, because it's unusual for a very active, child to suddenly stop doing things. Then, of course, many times, even here in the United States, when it comes to resources, in the pediatric world, they can do many more tests very quickly in pediatrics because the patients cannot tell you what is exactly going on because of their children. So there's a higher tendency, even in resource-rich environments, to have a lot of tests available and readily, covered by the insurance. While on the adult side, there may be more restrictions. But I think the awareness is there because the patient's parents or the patient's caregivers notice that something is wrong and take them to the hospital. While sometimes with the adults, especially with something like CIDP, that may be slowly progressive, what may happen is people blame it on other things. And even you get people who say, oh, you're just being lazy. Why are you just always tired? Why are you doing this? And that lack of awareness is what results in prolonged diagnosis. But I think it can be a challenge, of course, in pediatrics if the patients don't have any other symptoms and it's slowly progressive as well, because then, many times people don't pick on stuff until it's quite severe.
Thank you, Prof.
Thank you, Prof.
Any other questions?
Any other questions?
One final question. When do you say that you need to give the
more
IVIG
frequent in cases of CIDP, refractory to steroids, of course, and you've given your initial IVIG, probably going to the second IVIG. When do you determine that, I need to make it more frequent, rather than monthly, probably every 2 weeks? So, and we don't have subcutaneous IVIG, subcutaneous immunoglobulin infusion here.
Okay. So in general, if one were to go by the clinical trials, IVIG shouldn't be given any more than 2 grams per kilogram every 3 weeks. But the key point is if a patient tells you they receive IVIG, they feel better, and after 2 weeks, they start to feel worse again, then you may be able to justify going on that schedule every 2 weeks. You may have patients actually, when you start off initially every 4 weeks and they're doing well, you back off and go, let's go every 6 weeks, let's go every 8 weeks. And there's some patients who are doing well with their CIDP who you can actually get off IVIG. That's be a good situation. But typically in our environment, that happens in patients who are also on oral immunosuppressant medications like the azathioprines, or they may be on a schedule, let's say every 12 weeks. So ultimately, the standard treatment is 2 grams per kilogram, typically spread over 5 days, anything from 3 to 5 days, every 4 weeks. The clinical trial suggests efficacy every 3 weeks, but on a patient-to-patient basis, one can titrate the IVIG depending on how well they respond and how long that response lasts for. So every 2 weeks is feasible, especially if the patient's receiving the infusion, let's say, over 2 to 3 days. That's very possible. I didn't talk about other treatments that are been recently approved or on clinical trials for CIDP. Many of these are, if IVIG is a challenge, then of course, these are newer medications that will really be expensive. So I didn't talk about some of those, but the subcutaneous treatments also help because many times those can be given on a weekly basis by the patient at home. Of course, the patient needs to be well trained, or their caregivers have to be well trained, and then they have to receive access to the drug and be able to look after the drug so it doesn't get, doesn't decompose or get spoiled. So ultimately, what can guide you is response to IVIG and how long that response lasts. One has to also recognize that unfortunately you have the placebo effect. There are patients who can get IVIG and they feel great. And what does great mean? Do they really have objective findings to suggest efficacy for the IVIG, or is it just the infusion of the immunoglobulins that gives them that feeling? So sometimes it can be a challenge, but in the perfect world, if you had objective evidence of response, and you then noticed loss of that response after a period of time, then you can kind of time your IVIG on a cycle based on the patient's response.
Thanks, Prof.
Thanks, Prof.
Okay. Any comments, Sydney Rono, before we close? Sydney? Sydney might not be available to speak now. So thanks, Prof. I think it's been a long discussion. We're really grateful for you making time out of your busy schedule to talk to us, and thank you also for being available to consult and speak with our survivor patients, Collins and Violet, who have been battling this disease. So I think from us at the School of Medicine and from the Department of Medicine of Moi University, we're really appreciative of your effort to give this talk and the time that you've given to us. And we don't take it for granted that you did that this morning. That's back in the US, this evening for us. And I think on behalf, I don't see the Dean, on behalf of the School of Medicine, the Dean of the School of Medicine, the Principal of the College, and all the faculty and members of staff of the School of Medicine of Moi University, and all the affiliated hospitals here, we're really grateful, and we thank you from the bottom of our hearts for making this time. Hopefully, Prof, in future, and we hope that future is not too far away, that you'll visit us and see how Eldoret looks like and how Kenya in general looks like, and have a feel of how the practice here looks like as well, so that you can have a context for yourself. So thank you very much once more, Prof, and we wish you a happy Memorial Day back in the US, and all the best as you head back to work tomorrow. Thanks, Prof. And
my great pleasure. Thank you so much, GBS Foundation Kenya and Moi University School of Medicine for the invitation. It's my pleasure to share my knowledge with neurological knowledge in general, but also specifically in the autoimmune polyneuropathies, and very available with good notice and time and planning to be able to either visit or give another virtual talk so that I can educate more people. Please share the YouTube video with your colleagues, your social networks. If one wants to edit the part where I was having technical difficulty, that's fine. If not, it's fine. Either way, I think what's important is that the right people need to hear about these group of conditions so that they are aware not just of maybe not just the autoimmune polyneuropathies, but also peripheral nervous system disorders, neurological disorders, to be aware of that so they understand that there's a significant burden of these conditions on the health of the nation. Many times they're under-recognized. When they're under-recognized, they're not treated. When they're not treated, you have negative outcomes economically, socially. So I think it's important to share this with as many people as possible. And like I said, it'd be my pleasure to come back in one setting or the other and share my knowledge on this area of important healthcare, consequence to not just the patients, but also to the nation as a whole. Everyone have a great evening, and hopefully we'll keep the contacts going and look for more opportunities for interaction.
Thank you very much, Prof. Thank you very much, everyone, for coming. We wish you a great evening. Bye-bye.